All right, welcome back to the 18th Indoanesthesia 2021. This is our third segment of the day. This time we will talk about geriatric anesthesia. So this morning we already discussed about obstetric anesthesia, and then after that we already discussed a lot about postoperative pain management, and right now we will talk about geriatric anesthesia. As we know, we have a lot of geriatric patients, especially the surgical ones. So I think this is a very, very important and interesting session. This session, we will have three prominent speakers. We will have Dr. Bernadette Veering from Netherlands. We have Dr. Gabriella Bettelli from Italy. And last but not least, we have Dr. Richard Griffiths from the UK. And these sessions will be led by Prof. Nancy Margarita Rehata from Surabaya, Indonesia. For Prof. Rita, you may start the discussion. Prof,
Yes,
Prof,
okay.
I think you
Forget to unmute the microphone. Thank you, Krista. Again, welcome and thank you for your coming, our distinguished guests. And I'm call me Rita. I'm glad to be your moderator in this session. And I think it is the last session for this day, Krista.
No.
We still have one.
Still, okay.
Oh.
So
we're on fire today.
We will start now to make it short, and we will start with Dr. Bernadette Veering. The topic is geriatric anesthesiology. Where are we now? I think the CV is already shown on the screen. Yes, Krisa?
Yeah.
Yeah, okay. So you have 30-minute time to start now, and you have to complete it in 30 minutes. Please, Dr. Bernadette.
You still mute your mic, Professor Bernadette. Yes, good.
Yeah.
It's okay?
Yes, okay.
Oh, okay.
Do you hear me?
Yes.
Yes, clear.
Share. One second.
It's okay. Take your time.
Yeah, I just want to make it bigger. It comes.
Yeah.
Yes.
Here it comes.
Perfect.
Okay. It's okay. I start now. Okay.
Yeah,
Yes,
please.
It goes too fast now. Sorry. So first, I would like to thank the organizing committee for the invitation to give a lecture at this meeting. It's a pleasure to be here, and I want to thank Professor Susili Chandra to have a chance to communicate in this pandemic time. I live in Leiden at the university hospital, and it is a small university town with a lot of canals. As you can see here, it's called Little Amsterdam. Now, as anesthesiologists, we are faced with an ever-growing number of elderly people because the baby boom generation is increasing. As you can see here, the pink segment, we are now here, and these are all people born after the Second World War. So there's a huge segment of elderly people in the world. And as you can see on the right, it will rise in the next decades as well. So we are facing with a lot of elderly people. And as we know from daily practice, not all the elderly people are the same. Some people are playing golf in their 80s and others are lying in bed and doing nothing. And that's because in the elderly population, there are a lot of comorbidities. Some people have none, others have a lot. And above 65, a lot of elderly people have comorbidities, and we have to deal with that. A lot of cardiovascular diseases, but also pulmonary diseases and diabetes. And that can give problems. And as you can see here, the more comorbidities you have, the more risk you have, as you can see here, the more risk you have for mortality. So we have to deal with that. And the surgical outcome is decreasing in the elderly because of a high incidence of comorbidities. 30% of patients have even 3 or more. And also the surgical outcome is decreasing with emergency operations and with some surgical procedures, especially with upper abdominal surgery and thoracic cavity surgery. Now, the preoperative assessment is performed to identify factors to increase risk of complications and to recommend a treatment plan to minimize those risks. And the preoperative assessment is crucial for planning the optimal perioperative care in the elderly. In the last 5 years, a couple of guidelines have been issued for preoperative evaluation and perioperative management. The American College of Surgeons and American Geriatric Society and the Association of Anesthesists of Great Britain and Ireland and the European Society have guidelines which focus especially on optimal preoperative assessment. They recommend which factors should be evaluated to assess surgical risk in the geriatric patient. And I believe Dr. Gabriella Bettelli will focus much more in detail on this topic. Here you see a checklist mentioned in American guidelines for optimal preoperative assessment of the geriatric surgical patient. It involves physical, psychological, functional, and social issues, and the same issues are mentioned in the other guidelines as well. I will focus especially on frailty, which is a relative new concept in the perioperative care, especially for the anesthetist. Now, what is frailty? Frailty is defined as an important syndrome of decreased physiological reserves and resistance to stress. This is caused by cumulative decline across multiple physiological systems, and this may lead to vulnerability to adverse outcome. It represents the overall result of decreased physiological reserves across multiple organ systems. And the frailty phenotype was reported first by Freud, an American. This consists of 5 criteria: unintentional weight loss, mostly more than 5 kilos in the last 6 months, self-reported exhaustion, physical weakness, slow walking speed, and low physical activity. Now, frailty was defined when 3 or more of the above criteria were present. And frailty is not synonymous with either comorbidity or disability. However, the more comorbidities you have, the more the chance you have to be frail. And frailty was found to be a predictive tool for postoperative severe morbidity and mortality. I will explain this graph. As an anesthetist, we are used to use risk factors for the ASA score or the Lee risk index or Eagle risk index. These are more surgical things, but the ASA score, we use it daily to get an impression of what kind of risk a patient will have postoperatively and during the operation. And here you see the ASA score. And when you do on top of that the frailty score, you will see that there is an increased risk for mortality. So preoperative scores such as ASA score don't include frailty. These risk scores are only a tool to measure the physiological reserves. So consequently, frailty on top of the existing risk tools can increase our ability to detect patients at risk complications. The benefits of such a preoperative assessment is that we are doing risk stratification. And the question is, can we optimize the frail patient preoperatively? Now, with proactive care, of all the people undergoing surgery, we can probably improve their outcome before doing them to optimize them preoperatively. So intraoperatively, the focus is to minimize the stress response to surgery with less side effects in order to optimize the postoperative outcome. With increasing age, anatomic and physiological changes do occur, And as a consequence, changes in the pharmacokinetics and pharmacodynamics will occur. And therefore, the sensitivity of drugs will increase. However, one should deal with the fact and realize that increasing age is associated with a large inter-individual variability in dose requirements. The total body composition changes gradually with increasing age. Intracellular water content declines as people age, which may lead to a decrease of the total body water. Consequently, the adipose tissue will relatively increase somewhat more in women than in men. And disposition of a drug, that is the distribution and the elimination, may be altered by those changes in body composition. For example, in the case of a hydrophilic drug like morphine, a reduction of the apparent distribution volume may occur. And that means that you will have higher corresponding plasma concentrations of morphine. On the other hand, the distribution volumes of lipophilic drugs like the opiates would be expected to increase with lower corresponding plasma concentrations and increase in the corresponding elimination half-time. Here you see a simulation of a TIFA of a propofol in a younger and an older patient. The older patient is the red curve, the upper curve, and you can see there's a difference in concentrations. This is higher, and that's because there are changes in the pharmacokinetics, and therefore there's a higher concentration during the infusion of propofol in an older patient. And this is because of changes in body composition and metabolic clearance. Also, the central volume is decreased. Elderly people are more sensitive to the hypnotic effects of propofol than are younger persons. Aging alters the pharmacodynamics. Here you can see that there are changes in the pharmacokinetics for the unconscious effect. To have an 80% to have, you see here, 80% chance to be unconscious, and you see in a 25-year-old patient, he needs much more concentration to have the same effect as an older one of 75 years, this dose response curve for unconsciousness. So the changes in the pharmacokinetics and dynamics lead to a reduction of the induction dose and infusions of propofol. A 50% reduction in bolus dose, and for maintenance, a 30 to 50% lower infusion rate of propofol is needed. Also, the drop in blood pressure is more profound than any other dose of propofol, and it will reach later in the elderly. As you all know from daily practice, here you can see it takes 10 minutes and here 5 minutes to have a drop in blood pressure, and you see it's even more profound in the elderly. Now, remifentanil is also used in daily practice in the elderly, and age affects also the pharmacokinetics and pharmacodynamics of remifentanil. Here you see that the central volume is decreasing, and here the clearance of remifentanil is decreasing. These are the pharmacokinetics. However, also there are changes in the pharmacodynamics. You see the EC50, I will explain what that is decreasing with increasing age. The EC50 is the affected concentration to have a chance to have a drop of 50%, a 50% chance to have a drop and changes in the EEG. So elderly people are much more sensitive for the brain effects of remifentanil than younger ones. And also, it appeared that the bolus dose should be halved, and the infusion rates decreased as well to 1/3 in the elderly to achieve the same effect. Also, we know from daily practice that elderly people are much more sensitive to the effects of benzodiazepines. Elderly people exhibit a greater dose drug response. The increased sensitivity to midazolam, as you can see here, you need less dose in the elderly, and here you see a dose response curve of midazolam, and you see it is to the left, and that means this dose response curve that you need much less concentration, effect site concentration, than in the younger ones to have the same effect. And this, the changes in the sensitivity is probably based on changes in the pharmacodynamics. And also, the relatively new drug Sugammadex is used in the elderly as well. The dose of Sugammadex to facilitate rapid reversal from moderate neuromuscular blockade induced by rocuronium in this study was the same in younger and older patients, as you can see here. Now, this is a relatively important table because you can see here the differences in intravenous drugs between young and elderly people. It's nearly half the dose from all the drugs, as you can see here. So that is what you should take in mind, that you should take half of the dose in the elderly. Also, we know from daily practice that elderly people need less volatile agents because with increasing age, the minimum alveolar concentrations, the MAC, of inhalation agents gradually decreases with age and can be as much as 30% less by the age of 80. So just to summarize, for the intravenous anesthetics, there is an enormous inter-individual variation, and therefore you should titrate till effect. Start very low and go slow and wait for the effect. Also, we know from daily practice that there are a lot of anatomical difficulties with regional anesthesia. As you can see here, there's an exaggeration of the kyphosis and a flattening of the lordosis, and this gives technical problems, especially with spinal and epidural anesthesia. With the clinical profile, one can say that the duration of neuroblockade is longer in elderly patients because of atrophy of the nerves, and also the conduction velocity of the motor nerves is decreasing. So elderly people are much more sensitive for local anesthetics, so you need smaller doses. For example, here you see a peripheral nerve blockade, and you see that the durations of the sensory block and the motor block is increased with a peripheral nerve block, and it was with a supraclavicular block, young versus old, with ropivacaine. Dextrometamidine is a selective alpha-2 agonist and can be used as a sedative in combination with regional anesthesia. The dose to achieve adequate sedation was lower for older patients. This is an effect dose study. And you see here are the young old group, 65 to 70. They needed on the average 0.57. These are the very older ones, 75 to 85.31. And the very young ones, they need much more, even 50% more. And with this dose, there were no cardiovascular effects like bradycardia and hypotension. The elimination time for this dose is 2.5 hours, so you only can use a single dose of this drug for sedation and not for longer durations. Every day we have to make the choice if an elderly patient will receive regional anesthesia or general anesthesia, and therefore we have to look at outcome results. Now the next speaker, Dr. Richard Griffiths, he is an expert on hip fractures, and he will go through that topic. However, I just want to say that there's still controversy if regional anesthesia is better than general anesthesia, and a lot of studies are ongoing at this time to see the difference on outcome in regional anesthesia versus general anesthesia with hip fractures. And I'm sure Dr. Griffiths will go into the details. So there's still not a clear answer on this topic. As the number of elderly people are increasing, we are unfortunately confronted with an increasing number with patients with dementia. And dementia is a common condition in the elderly population, with an estimated prevalence of 8% in persons above 65 years and up to 33% of people above 85 years of age. The most important risk factor for developing dementia is increasing age. And as we all know, dementia is a neurocognitive disease with slow progressive loss of memory. Recently, a guideline statement for the perioperative care of people with dementia was published in Anesthesia. The guidelines gives recommendation how to deal with patients with dementia in the perioperative phase. The guidelines include some practical recommendations for anesthetic daily care. The burning question, of course, is if their cognitive state may deteriorate in the perioperative period. Now, avoidance of benzodiazepines and anticholinergic drugs, avoidance of excessive depths of anesthesia is also recommended, and also not to give too many opiates. And also, one should do optimization. At the end of the preoperative assessment, a clear management plan should be in place, which should include optimization of comorbidities. Of course, the best anesthetic technique to use in patients with cognitive impairment is still uncertain. Certainly, the best technique is one which provides anesthesia while minimizing physiological and psychological stress, and of course allows for a rapid recovery of cognition. Postoperative delirium in elderly patients is a frequent complication, approximately 50 to 20% of major operation, and is associated with poorer functional recovery, longer intensive care stay. It has a sudden onset, a reversible state of and fluctuates during the days. It often starts in the recovery room and occurs up to 5 days after surgery. A few therapeutic measures for postoperative delirium are available, and prevention remains the best option. The European Society of Anesthesiology have composed evidence-based guidelines and consensus-based recommendations for the prevention and treatment of postoperative delirium. In this table, you see factors how to prevent and treat postoperative delirium. The recommendations for prevention and treatment are summarized in this table. I will focus a little bit more on the depths of the monitoring depths of anesthesia. It was recommended to BIS-guided anesthesia with values between 40 and 60, which is associated with not too deep anesthesia. However, I will show you that this issue of the depth of anesthesia monitoring will continue to be controversial. Also mentioned is adequate pain assessment and treatment, and I will give some details about that issue as well. Very recently, in the JAMA, it was investigated whether EEG-guided anesthetic administration decreases the incidence of postoperative delirium. In 1,232 elderly patients between 65 and 95 years of age undergoing major surgery. Patients were randomized to receive either EEG-guided anesthetic administration or the usual anesthetic care. All patients received general anesthesia with a volatile agent. The primary outcome was delirium. Conclusion is that in older adults undergoing major surgery, EEG-guided anesthetic administration did not decrease the incidence of postoperative delirium compared with the usual care, despite successfully reducing anesthetic exposure and duration of EEG suppressed. Also, a few months ago in anesthesiology, the same protocol was used, so also EEG versus usual care in patients which were cognitively impaired. And surprisingly, the results was the same. So the incidence of delirium was not decreased in patients with EEG-guided monitoring. So there are still a lot of questions to be answered. Advanced dementia patients may be at a substantial risk for undetected or undertreated pain. Morrison examined the treatment of pain in hip fractures in patients with advanced dementia and compared the pain treatment with patients who were cognitively intact. They had hip fractures. Pre- and post-operatively, you can see here, the upper one here, this is preoperatively and this is post-operatively. As you can see here, the patients with advanced dementia received substantially less morphine than the cognitively intact patients. So patients with advanced dementia received only 1/3 the analgesia of their cognitively intact counterparts. Unfortunately, inadequate analgesia contributes to delirium post-operatively. And we all know that it is very difficult to adjust the pain treatment in elderly people with advanced dementia. You only sometimes hear the screaming and see the facial expressions. So there is a need for good pain assessment in persons with dementia. We need very good observational pain measurement tools with an indication of psychometric properties with facial expressions, body movements, and vocalization. These are all proxy rating scales. And fortunately, in Europe and in the world, there are some scientific groups who are busy to make very good proxy rating scales so that we can have in the near future better observational pain measurement tool for the elderly with advanced dementia. So, Mrs. Chairman, ladies and gentlemen, just to summarize, I've shown you that the geriatric population is increasing and it will increase in the coming decades as well. You have to keep in mind that there is an enormous inter-individual variability. Elderly people are more vulnerable because they have a high number of comorbidities, and the risk is also increased in emergency operations and especially in thoracic and abdominal operations. Frailty, which is a relatively new concept for the anesthesiologist, independently predicts post-operative complication, as I have shown you on the graphs. Risk assessments tool will give information for intervention to reduce post-operative complications and mortality. I've shown you that the sensitivity is increased with a huge inter-individual variability for the intravenous anesthetics, and also with local anesthesia, you need less. So with the intravenous anesthetics, you should titrate the drugs and slowly and monitor effects. There's a growing number of people suffering from dementia and pain, and there is a chance to have under-treatment of acute pain for the cognitively impaired patient, and therefore inadequate analgesia will increase the incidence of delirium. So we need very good proxy rating scales to observe pain in the patients with advanced dementia. Well, Mr. Chairman, ladies and gentlemen, I thank you for your attention. Thank you.
Prof. Rita, you have an unmute, Prof.
I start to be dement also.
You're geriatric as well.
Well, thank you.
Thank you, Professor Veering, for your so comprehensive lecture. And the question and answer sessions will later on. So we come to the next speaker, Professor Gabriella Bettelli from Italy. Please, you have 30-minute time for the presentation, Professor Gabriella Bettelli.
Good afternoon, ladies and gentlemen, belonging to both the Indoanesthesia family and the audience, and also to the other co-speakers. Regretfully, in this edition of Indoanesthesia, we cannot shake our hands as we usually do, but there is a link, a so strong link among us, that is much more powerful than Zoom, Teams, or all the other internet-based links that can be used today. Its power stays mostly in the passion we all have for our work, and is in the name of this passion that I'm happy to share with you this educational moment. It's a great honor and pleasure to me being here. And again, I thank Professor Susilo Chandra for inviting me to this session, to this Indo-Anesthesia Congress. My lecture will focus on decision-making about surgery in the elderly. An issue that can be very problematic, mostly when the patient is comorbid, frail, defidated, with impaired functional status, and the planned surgery is a major one. I would like to share my, wait a moment. Can you see my slides? Yes, I think so, yeah?
Yeah.
Okay. But I cannot proceed. Yes.
You can use the keyboard. Yeah.
Yeah, okay. I'm here. So, as it was widely described by the first speaker, Professor Bernadette Veering, today more than 50% of surgery in the world is performed on patients aged 65 years and more. This is mostly due to two main causative factors. The first one is the global population aging, but the second is that aging increases the need for surgery. So the number of patients undergoing surgery after 65 years is continuously increasing, and the demand for surgery is also expected to increase as the population ages. In this scenario, there is a great reason of concern. As it was recalled previously, despite advances in surgery and anesthesia, many papers report that older adults are often at increased risk of postoperative complications and mortality. Complications cardiac or respiratory that can bring the patient to the intensive care unit admission, or cognitive, like postoperative delirium, which is frequently, mostly when later diagnosed, recognized, and treated, can lead to irreversible dementia. But also older patients undergoing surgery are exposed to the risk of postoperative geriatric syndromes, like incontinence or reduced ability in daily life. The quality of life may be impaired, and in the worst scenario, the patient may need to be institutionalized. Of course, this is most true in comorbid, complicated patients, but also I add that this is an area in where our role as anesthesiologists is pivotal, because we need to adequately investigate the patient before surgery. We need to learn that the habitual reference points we have, the ASA classification and the risk that accompany the planned procedures are not sufficient to describe the risk factor this patient has, are not sufficient to allow the implementation of adequate perioperative measures in order to improve the outcome. Consequently, as I told, the preoperative evaluation of elderly surgical patients should be appropriately performed. Comprehensive geriatric assessment is pivotal. We cannot avoid using this, and I will be more precise in the next slides. And of course, in this situation, decision-making can be hard. A schematic approach to the process of decision-making should consider three main factors. Of course, the patient with his or her health function and functional status, and comprehensive geriatric assessment is fundamental in adequately investigating it. We also need to investigate the decision-making capacity of the patient, which is related mostly to his cognitive function, but not only. We also should consider his or her existential perspective. I like this expression to indicate what the patient wants to be of his or her life. Another issue important is what may I expect from rehabilitation? Is it feasible, fruitful? The second element, of course, is the surgical treatment. The main aspects to consider are invasiveness, duration, the impact on vital functions, and if we are facing an emergent or an elective surgery, and when the situation is really complicated, what are the possible alternatives? The third element important to carefully investigate in order to take the right decision is what are the expected results? What are the needs of the patient needs? The surgery is aimed to give an answer, to prolong the life, to increase the quality of life, to increase independence, to obtain reduction in a chronic pain. But before entering in the analysis of this decisional tree, I would like to emphasize the concept that the main decision maker is the patient. There are two fundamental principles, both related with the importance of the patient as the main decision maker. The first one refers to his or her decision-making capacity. I understand and I am able to communicate about my decision. However, we never should forget that there is an international law principle shared everywhere, the patient's right to self-determination. I have the right to choose about the treatment that the doctors proposed me. Starting from the patient, the first element that we should investigate is his or her clinical and functional status. Comprehensive geriatric assessment is a set of biological measures which is aimed to describe the need of the patient in order to understand what are the right measures to answer these needs. Of course, at the first place there is the investigation about his or her health status, but it is not enough to simply note on our record that the patient is hypertensive, that he had a cardiac infarction 1 year ago, and so on. What is important is that for every comorbidity, we make a sort of balance. How hard is the impact of such a comorbidity on the global function of this patient? What is the answer to the medical treatment? Is it effective? What is the prognosis? How is this illness proceeding and evolving? About the aging processes, it is quite difficult to investigate in a very precise way the pathophysiological impact of aging on organs and apparatus. Of course, we can, we have the cardiopulmonary exercise test, but we cannot use such invasive and costly investigation on any patients. When it is justified, of course, we do it, but it is not a routine approach. associated condition and medication, of course, are very important. About the medication, we should remember that in the elderly, the use of inappropriate medication in accordance with the Bayer's principles is regretfully a very great area of concern. So medication reconciliation before surgery for us anesthesiologists is a very, very important step. We also have to investigate in the frame of a comprehensive geriatric assessment, the cognition, whereas with the clock test or the mini-mental or whatever you prefer, we should exclude that the patient has sensory problems, because a patient that cannot hear or that cannot see is the patient that has difficulties in understanding what we are saying him, and that is difficult that I have to know and I have to manage. Depression also is another frequent condition in the elderly. Geriatric depression test is simple and easy to be administered. When I know that my patient is depressed, I have two main important information about him. The first one is that he will be not too much prone to follow our indications. And the second one is that he will be very, very hard to be treated with the postoperative pain. The level of independence, of course, is important because it gives me an idea of the functional status itself. Nutrition also is important. Mean nutritional assessment is the test usually used. Malnutrition is frequent in the elderly. About frailty, Professor Veering also spoke, and I don't repeat. And the risk of fall also is another important factor. These data will help us in predicting postoperative complications and outcome, identifying the patient needs, and defining the measure aimed to preoperative optimization and surgical risk reduction. Also, these result will contribute in evaluating the patient ability to understand. This will be reached with the cognitive evaluation, and the availability of family support in discussing about the decision, because another area comprehensive geriatric assessment investigate is the availability of family or social support. The second area that it is very important to investigate in the older patient is the capacity of self-determination. Cognition, of course, is very important and a fundamental element, because the patient should understand what we are communicating him in order to take a decision. However, the self-determination capacity is something more comprehensive. In accordance with the self-determination theory that was elaborated by some psychologists 2 decades ago, there are three main elements in the self-determination capacity. The first one, of course, is the competence, the capability to learn, to understand what we are saying, but also there is the feeling of belonging, which is, in other words, the need of relationship. I belong to a community, my family, my friends, the other older persons that share with me the resting house where I'm living. This is important because this element describes the weight that the patient gives to what regard his life. And the third element is the need of autonomy. I'm able to control my life, and I need to be me, myself, to control my life. So the self-determination capacity requires a good approach from us, both in cognitive terms and in knowledge about these dynamics that are quite far from our usual daily world. About the self-determination capacity, various scenarios can occur. For the most favorable is that we face a mentally and physically intact subject, with a good quality of life, is independent, or there is a minimum cognitive impairment that requires some lifestyle adaptation. In any case, however, the control about decision is preserved. In such cases, the main aspects to consider are, of course, our duty to offer clear and understandable information. And second, the patient's self-determination right. But there are also some more challenging situations. For instance, a dependent subject with reduced mobility, where in any case personality and dignity are preserved. However, there is a reduced range of interest and there is need for help in decision-making. In such a cases, what can be useful, of course, is involving the family. That is why it's important that in my preoperative evaluation process, I investigate through comprehensive geriatric assessment if this patient has family or social support. Providing verbal information, of course, but using, in accordance with the neuro-linguistic programming principles, all the tools that can stimulate the interest of the patient. For instance, leaflets, brochures, or visit the facility. I made this in IRCA, in the hospital where I was the director of the geriatric anesthesia department, and to visit also the operative room, or, if it's possible, providing psychological support. In the worst scenario, I will face a bedridden or in wheelchair subject who need help in assuming food, in washing, in using toilets. There is a severe cognitive impairment. Interests are not anymore retained, and decisions about himself life are not understood. In such a case, the fundamental issues are sharing with the family members that only minimal strategies of care are indicated. Of course, treating pain remains a duty. The third element is the so-called existential perspective. In other words, the patient attitude about his residual life. There is a patient that say I want to be here in 1, 2, or 3 years because my grandson will marry, or I want to live as long as possible, or I don't want to become dependent, I don't want to have ileostomy, mastectomy, and so on. How to manage these situations? When the patient imposes conditions, first of all, we should respect the patient's willing. However, we should give him enough time to think about, because the emotional reaction to the novel that he has to undergo surgery is something troubling and requires time to be metabolized. Also provide psychological support whenever this is possible. In general terms, the patients who care to live as long as possible and privilege the living toward independence, probably they will be willing to pursue high-risk surgery. Those, on the other hand, who prioritize the function and independence may refuse a surgery that requires long rehabilitation or has the risk of placement in a long-term care. A further aspect to consider as the role preoperative optimization can exert. Is prehabilitation feasible on this patient and in my hospital? Did I organize a pathway for preoperative rehabilitation? What are the expected results? What about the expected patient's cooperation? And is mostly the time frame rehabilitation requires appropriate with the clinical situation? The second aspect is, of course, the surgical treatment, of which at the first place we will investigate invasiveness, duration, and impact on vital functions. The surgeries at the highest impact are, of course, open, cardiac, thoracic, and abdominal. In patients with reduced functional status, morbidity, or frailty, is a pivotal importance to implement strategies aimed to reduce this impact. For instance, prefer minimal invasive techniques, implement ERAS strategies to reduce the surgical stress response. Again, about the surgical treatment, there is the problem emergent or elective surgery and possible alternatives. As a possible example of emergent surgery in the elderly, considering also that we have Richard Griffiths, that is an expert on hip fracture repair, perioperative medicine, I decided to concentrate my attention on bowel obstruction, which is, together with the hip fracture, a very frequent and a serious surgical emergency in the elderly. In the 60% of cases, the cause is the cancer obstruction. And what should I do of a very complicated, frail, comorbid patient arriving in emergency with the bowel obstruction? Of course, some surgical strategy has to be implemented. Probably strategies such as decompression before colonectomy, using stenting or palliative surgery will allow to solve the most emergent need of care and to create the condition for minimally, as much as possible, improvement in the geriatric, in the global condition, and then to proceed with the surgical treatment aimed to remove the obstruction. Another important aspect is the expected results from surgery. What patient needs surgery is aimed to answer. Do we want to prolong life, to increase the quality of life, independence, to pay removal? About prolonging the life, there are two main concepts. Lifespan is a dimension that describes the maximum number of years an individual can live. It could be even 122 years. However, this is a theoretic measure valuable for all the living humans. At the contrary, life expectancy is an individual measure, is an estimate of the average number of years a person can expect to live, and this, of course, affected by the individual health history, genetics, and lifestyle. This concept is very important when we have, for instance, a patient that presents a severe pre-existing condition, for instance, cardiac congestive insufficiency belonging to the third or fourth NIA class. In such a patient, a surgical treatment which aims to increase the life expectancy of some years may be a nonsense. We should clearly consider this issue. Finally, about the increased quality of life and independence and pain reduction, I decided to check in the literature with reference to the main the three macro areas of geriatric surgery, which are cardiac, oncologic, and orthopedics. About cardiac surgery, I found two systematic reviews. The first one showed that quality of life is improved in octogenarians after cardiac surgery in the majority of cases, 81, 82%. However, the authors couldn't find predictive models for the other patients who didn't take advantage from surgery. Following systematic review, investigating quality of life after elective cardiac surgery, found that in the majority of studies, the mental and physical improvement occur in the first 2 months, and that both cognitive deterioration and long intensive care unit stay are predictors for negative outcomes. About cancer surgery, there is a guideline, a practical guide issued by the International Society of Geriatric Oncology, addressing the quality of life needs of patients with cancer. And they put at the first place the use of comprehensive geriatric assessment in order to individuate patient needs and define strategies to treat. To investigate the patient goals. A patient who has a cancer has a limited life expectancy, and his existential perspective is an important factor to take into account. What is important also is to adopt models based on multidisciplinary care to assess social and psychological disorders, to promote the compliance of the patient toward the treatment, for instance, reducing as much as possible fatigue, correcting anemia, and implementing strategies to prevent postoperative nausea and vomiting. In orthopedics, this is not a systematic review, but is a study on more than 700 patients. The main findings were that spine fusion, total hip, and knee arthroplasty are performed with the specific aim to alleviate pain and to improve quality of life, to improve, for instance, the level of independence, because the patient can walk more easily. In this group of patients, the in-hospital complications ranged at 17.5%, which is not so impressive. What is important is that only minimal differences were found between over 65 and the group 65-79 years old. Very older patients may benefit from this elective surgery, mostly when they have few or no comorbidities. So, to conclude, deciding about surgery in the elderly can be hard, and clinical and psychological evaluation are fundamental, but also is important our communication skills and our communication style. The decision involves not only clinical but also personal issues. Patient preferences are important, and the patient may need help in deciding, and we have to give him the help he needs, involving in our perioperative team care a psychologist in case there is need for his collaboration. Also, at the end of the analysis, the last question that needs a solid answer is, are in accordance the patient's needs, the surgery goals, and the expected outcome? This requires a team-based discussion between the surgeon, the anesthesiologist, the geriatrician in case he is involved in the perioperative care, and the nurse. The team includes all these persons.
Wow.
And another thing important is, was the communication about this point appropriate, respectful, and clear? So at this point, I think that a question important is this one. What, as healthcare operators, we cannot help to do, to learn, or to practice? First, optimize our relational capacity. Second, nurture our communication skills. Third, to be always available to understand the patient needs. To emphasize this concept, I hope that what I prepared will work. In other case, let me see. Yes. So there is a man that announces that doctor is arrived. Then the doctor starts speaking, but speaks in a dog Latin. And so the patient says, but he's talking a language we don't know, we cannot understand. I hope to be able to satisfy your curiosity about this subject, and I say to you all, terima kasih. Thank you.
Terima kasih. Terima kasih kembali, Professor Bettelli. It is nice to have your lecture that reminding us about the things that we have to remind to decide before we decide to have surgery in elderly. Thank you very much, and also for the last video. Okay.
Do you know where does it come from?
I don't
From
know.
the Così fan tutte, Mozart.
Oh,
It's an opera of Mozart. The Così fan tutte.
Opera. Thank you very much. And so we have to move to the next speaker, and the last one but not least, Dr. Richard Griffiths. Dr. Richard will present us about the hip fracture operation guidelines, yes?
Yes, that's right. Yeah.
Yeah, you have 30 minutes for the presentation. You can start now, please.
Is the screen up? Can you see the slides?
not yet.
Not yet. We can
Not
see
yet.
you, but not the slide.
Right. I've got my slides up, but I've got no control over them at the moment.
Yeah.
Go ahead and share the screen.
Yeah, share the screen first, please.
Are you using two screens?
Yeah, I can't get out of it in my computer. Can you stop?
All right. Yes, just stop sharing first.
Yeah, but I'm in the presentation. I need to get out of the presentation. And I can't because you've got the screen. You've controlled my screen.
Wait, hold on a second. I think we don't actually request any remote control.
Hang on. I can't get out of my screen.
All right, all right. Do you see the Zoom button at the lower right or the?
No,
Yeah.
all I've got is my slideshow on my machine.
All right. Can you please escape?
Escape first.
It won't let me do it. It won't go out.
Oh,
Do you want me to run the slides?
You've got my slides. If you run them,
Second.
I need to get out of this. I can't get out of it.
Okay, hold on a second.
For some reason, I cannot get out of the slideshow.
But can you see us in Zoom?
I did see you until I went to full screen.
oh.
Yeah, it's okay.
Jadi,
How do I get out of end show?
All right, all right. Let me. But you're not actually sharing anything.
Right. So do you want me to share screen now?
yeah. Yes.
Yeah, I just
It's
okay
work
now.
now. Yeah.
Have you got it?
Yeah.
Yeah.
Execute the slides. Can you?
Show your slide. Yeah.
Yeah, okay.
Yeah.
Put
Yeah.
it in the full screen.
Right,
It's
you
all
okay? You're happy to go now?
Yeah.
Okay, right.
Make it full screen.
Wait.
Okay,
Can you
full-
make it full screen? Can you press the slideshow? Yeah. And then click. Yeah, they should do it.
Is that
All
it?
right. Oh, can you choose the swap displays?
Swap
see?
displays in the right, at the left.
Left,
Left
Yeah.
up.
slow, use slideshow.
Swap display.
Yeah, I can't do that for some reason.
Okay.
I have your slides here. Do you want me to run the slides?
Well, it'd be a lot easier, man. I did send them to you guys.
Yeah, yeah. All right. Sorry, I will stop your screen sharing.
Yeah.
Is this your slide?
Okay.
Okay.
Can you see your slide?
I need to stop the screen. Hang on. Let's.
Yeah. Stop share.
I can see my slides. Yes.
Okay.
Right. Are you happy for me to go?
Yes.
Just give me the cue to go to the next screen. All right.
Next slide.
Yeah.
All right.
Hang on a minute. Right. Right. Okay. So do you control the slides or do I control them?
Chrisas,
It's on me.
control.
It's on me. It's on me.
It's a lot easier if I can control the slides, to be quite honest with you.
So, do you want to try once again?
Yeah. So what settings do you want me on?
Full screen.
Richard, can you try the share screen once more? Right?
I can't get, hang on, share screen. Yeah, okay.
It's all right. Yeah, doing well.
Yeah.
And then can you go to the PowerPoint?
Go to the PowerPoint, yeah.
Yeah.
Well, I'm on the PowerPoint.
Oh, this is on the PowerPoint. Yeah.
It's okay now.
It's working now. It's working.
Okay,
now.
right.
Yes.
Let's go then, guys. Sorry about
Yes.
that.
Yes.
Okay.
Okay, so sorry for the technical hitches. Sorry can't be with you today. It's obviously been a difficult year, but in the melee, these new guidelines were published, and hopefully everyone who's a delegate will have got a copy of them. I sent them through they are free as well. I've got some declarations of interest, none at all financial. I've been chair of a number of guidelines: hip fracture, surgery and dementia, surgery in the elderly. I was a member of the NICE group on hip fracture, and I've recently been a member of the NICE clinical guideline in England on hip, knee and shoulder arthroplasty. So in 2011, these were published, and they're the first comprehensive anesthesia guidelines for hip fracture. These new guidelines have been updated, and what they do reflect is multidisciplinary care, some new drugs, particularly the new anticoagulants, and they focus heavily on three themes. That's remobilization, re-enablement, and rehabilitation. I think the really big move is to get anesthesiologists out of the operating theatre onto clinical situations like wards and preoperative meetings as well. So hopefully you've received these guidelines and please use them for your own departments. So we don't want to be confined to operating theatres. I think the term perioperative physicians is starting to be used about anaesthetists. So we're involved preoperatively, intraoperatively, and very importantly, postoperatively. Now, hip fracture is a very big problem. It's not confined to Western countries. In fact, the biggest growth area in hip fracture is in Asian countries. Of course, we do also recognise that the further away you are from the equator, the incidence is very high, and it's the highest in Norway. That may reflect a lack of sunlight. So they are just as relevant in Asia as they are in Europe. Anaesthesia has a very important role, and make sure that one member of your team sees the patients the day after surgery. This just looks at the incidence, the standardized hip fracture rates across different countries. And you can see that in women, it's pretty high in Hong Kong, Singapore, almost the same as some parts of North America and Europe. The overriding principles of hip fracture anesthesia were laid down in a document published in 2018 by an international organization called the Fragility Fracture Network. And I'm quickly just going to go through these. And this is truly international, multinational, and also this was done with other specialties involved as well. So I'm going to highlight a few of these. Principle 2, anesthesia and surgery should be undertaken by an appropriately experienced anaesthetist. So very important, you do not leave these cases to people who are trainees or those with little experience. You should participate in developing formal hip fracture care pathways, particularly with preparation for theatre. And finally, I want to highlight this principle. All trainee anaesthetists should receive specific training in providing perioperative care for people with hip fracture. That's very important when you consider that I am no longer a provider of this type of healthcare, but I may well become a consumer in the next few years. So I want the trainees to know what they're doing. The first thing also to really try to emphasize is that despite the fact that many of these patients are frail and elderly, surgery is life-saving. There's no doubt that conservative management of hip fractures is a death sentence for patients. So it is, in fact, this is an article from England. It is very safe to anaesthetize ASA4 patients. 98% of them survive for 3 days post-operatively. And the important thing that you're doing here is relieving pain. If you leave a patient with a hip fracture, it is very, very painful. This really reflects 2 important things that have happened. Specialized physicians, orthogeriatricians who just deal with hip fracture patients, and also the awareness that anesthesia has a role to play in the perioperative care of these patients. The one thing that all of you want to know is, does regional anesthesia have any advantages over general? And I know Bernadette has already mentioned the REGAIN study. This is a study being taken in the United States. They've recruited 99% of the patients. I don't suspect they'll find an answer. Unfortunately, there have been very limited, well-controlled, randomized controlled studies looking at spinal versus GA, but that study is almost ready to be written up. There is a problem of sedation in any regional anesthesia technique. I never sedate patients, but if you do sedate them in the elderly, it's very likely you're giving them a GA. So if we look at our guidelines, I'm just going to quote this for you because I think this is important. The Working Party considers that any difference in outcome between anesthesia types is likely to be small in comparison with the effects on outcome of trauma, surgery, orthogeriatric care, and patient factors for people with hip fracture. So our maybe 1 hour involvement, maybe how we do it, and GA versus spinal, has little impact. It may be because there's genuinely no difference, or more likely because what we measure after hip fracture basically are too variably defined and temporally disconnected if you consider that we are only available for 1 or 2 hours episode of anesthesia. The other study which is going on, the iHope study in Germany, that is another GA versus spinal. They've so far recruited about 500 patients. They've got another 500 to go. However, what we do consider is how you deliver anesthesia to be of greater importance than the type of anesthesia delivered. You must make sure the patient is resuscitated, and very, very importantly, they must remain normotensive throughout the procedure. Now, harking back to a study that we did in 2013 and 14, looking at hip fracture in England, and this is data on 11,000 patients from the National Hip Fracture Database. So this is only 8 years ago. 33% of all our hip fracture patients had a mean arterial pressure of less than 55 millimeters of mercury. And that's 40% of all GA patients. We've already learned how elderly patients are very sensitive to pharmacology. I am convinced that most people give too much pharmacology to old people, and that causes hypotension, which is bad news. Because what it does is when we analyze this data, the lower the blood pressure, the worse the patients will do. And that's mortality at almost all time points, 5 days, 10 days, 20 days, 30 days. So you must make sure the patients are normotensive. Now, you've got this with the data that I've already sent you. This is actually an appendix to our guidelines on how to conduct hip fracture anesthesia. But I really want to pay tribute to this country. It's called Wales. It's where I'm from. My name, Griffiths, is a Welsh name. And this is work done by a chap called Dom Herford, where they've produced a laminate for the whole of Wales on how to conduct hip fracture anesthesia. Now, what the Association of Anesthesists have done is borrow a lot of the very good things that they've done. And we have got now this laminate, which is in the appendix of the guidelines, and it basically shows you what to do preoperatively, intraoperatively, and postoperatively. There are some things there on doses of drugs, particularly the doses of bupivacaine used in spinal anesthesia. You can get away with very low doses, and this reduces the problem of hypotension. A quick look at some other aspects of care. Preoperative and intraoperative nerve blocks are very useful. I know that already in Holland, paramedics are doing hip fracture blocks in patients' houses. A study is about to start in Wales, in Swansea, on that particular thing. So instead of the ambulance men or the paramedics going to the patient's home and giving them morphine, they will be doing nerve blocks instead, which obviously reduces the amount of opioids that you give. So there is no doubt that nerve blocks are very effective. And when we look at the evidence, it is overwhelming in elderly patients that you basically reduce the opioid load, improve pain scores, and most importantly, there's a very important term that was coined by Nikolai Foss. What nerve blocks give you is dynamic analgesia. So the patients get analgesia when you move them. Whereas with opioids, you get pain relief, but when you move them, the pain is still there. I'm going to go for a little bit now on anticoagulants, because this has been a major problem in the United Kingdom. I call it the last refuge of the serial anaesthetic canceller, person who doesn't want to do any work. Oh, anticoagulants delay the operation. 30% of all our patients are on anticoagulant drugs. Comprehensive guidance is available from the Association of Anaesthetists in our appendix, and hopefully you've all received a copy, and I'll show you some of it now. Every drug that comes along, basically the same tricks are tried. People try and delay surgery. Patients are on anticoagulant for very good reasons. They're on it because either they've got a cardiac stent, they're in atrial fibrillation, and if you stop those drugs, you're going to harm the patient. And there is numerous papers showing that if you stop these drugs and delay surgery, you harm the patients. So what we must be is very familiar with the pharmacology of these drugs. And this is the appendix, the laminate that is in our guidance. It goes through all the classes of drugs, aspirin, antiplatelet agents, through to heparin, through to the newer oral anticoagulant drugs. And this is a very simple guide. The thing that we all worry about as anaesthetists with these drugs is, can you do a spinal anaesthetic? And the risk of vertebral canal hematoma is always quoted. This is an extremely rare complication. And the important thing to remember is the risks of delaying surgery and or the patients developing thromboembolism greatly outweigh the risks of vertebral canal hematoma and perioperative bleeding. If we look at the newer drugs, particularly apixaban, dabigatran, rivaroxaban, we can see that in fact they have quite short half-lives. And if we look down at the bottom part of our laminate, you can see that you should be able to do surgery in patients with an eGFR of greater than 60 after 24 hours of the last dose. So it's very important that all your doctors record when the last dose of these drugs was given. And of course, if you can give a general anaesthetic, proceed and give a general anaesthetic if you are worried about the problems of a vertebral canal hematoma. Just to remind all the trainees who may be listening to this talk, you can work out how the drugs work by their name. Rivaroxaban, apixaban, doxaban all have factor 10A in their names. That's how they work. Dabigatran, AT is antithrombin. So you can work out how they work just by their names. The oxabans, they don't rely on renal clearance as much as dabigatran. You can see that dabigatran relies 80% on renal clearance, whereas the oxabans, it's only about 25 to 30%. So oxabans, these are the factor 10A ones, safe to perform spinal anaesthesia at 24 hours with an eGFR greater than 60. We are very grateful. Also, I'm going to mention another part of Britain, Yorkshire, famous for its tea and for getting, I think, more Olympic gold medals in 2012 than France did. That's just one part of Britain. But some very good workers there have worked on these new drugs and have produced this document, which again is very comprehensive on how to manage a hip fracture patient who may be on the new oral anticoagulants. Don't forget, you can always give a general anaesthetic, make sure the patients are normotensive, and it is perfectly safe to do a fascia iliaca block in patients on these drugs, even in the emergency department. Going back, the antiplatelet agents clopidogrel do not delay surgery. They're on clopidogrel for a very good reason, and if you're worried, do a general anaesthetic. And this is a paper, again from Yorkshire, which shows that if you delay surgery, hip fracture surgery, in patients on clopidogrel, they do worse. So do not delay them. A little tiny bit on transfusion triggers, which I know is very, very emotive. Our working party recommend a liberal transfusion threshold of 90 grams of hemoglobin per litre. It should be 100 grams for those with a history of any ischemic heart disease. And you have to remember, the average age in the UK is 84 now. Most will have an element of ischemic heart disease. It is very important to measure the hemoglobin after surgery, preferably in the post-anaesthesia care unit, because the patients do mobilize and rehabilitate better with a higher hemoglobin. Going back to our big national audit we did a number of years ago, just want to quickly mention bone cement implantation syndrome, which occurs when you do a cemented hemiarthroplasty for hip fractures. Now, we discovered that you've got a 1 in 200 chance of cardiovascular collapse in these patients. So you've got to be very aware of looking after the resuscitation of these patients, and everyone in the operating theatre should have a role to play when these operations go ahead. Because if the patient does have a cardiovascular collapse and they're positioned in a lateral position, You've got to cover the wound very quickly, get the patient supine, and make sure you get on with your resuscitation. So the important things for anesthesia are listed in this particular publication. The important thing, I think, is the patient should be resuscitated preoperatively. So they should have had at least a litre of crystalloid every 12 hours. You must make sure that the blood pressure is within 20% of where you started from, and you must have all your vasopressors ready on your anesthesia machine to go anytime. And this is very close communication between surgeons, anaesthetists, and theatre staff as well. Everyone has a role to play. So I think what the future is going to be, and it's starting to happen in England, that we've got hospitals which have now got just elderly trauma anaesthetists working in groups of 10. So everyone's singing from the same hymn sheet, because as we heard from the other speakers, this is going to be a major, major problem as the population ages. You have to give physiologically sympathetic anesthesia, specifically the blood pressure. Do not let it drop. We are a key member of the perioperative team, and post-operative visiting should be encouraged with good departmental and national hip fracture audit. Included in the new document, I'm just going to mention as I finish, another looming problem for all of us in the whole world. That's periprosthetic fractures. So this is a fracture occurring in a patient who may have had a hip replacement or a knee replacement a number of years ago. And evidence is emerging. This is a very major issue. And I've also sent this paper, which has recently been published, to the organisers, so every delegate should get it. And this is basically looking at what's happened in England in the last 5 years. What the red line shows you is how periprosthetic fractures are increasing. It's important because there's an OPCS code, and it's up on this slide, M96.6. The length of stay of these patients in our hospitals is 18 days. And this is a very expensive resource. I just thought I'd show you this. And if you look to the right-hand side of this graph, this is last March. The one thing, if you want to reduce periprosthetic fractures, is to keep old people in their houses, because this is the effect of lockdown. You can see that it actually dropped when old people weren't going outside because of our lockdowns last March to June. So periprosthetic fractures, that's going to be a very, very big problem. And I think we're only just starting to realise these need to be treated as comprehensively as hip fractures. So in summary, anaesthesia has a crucial role in hip fracture care. Our latest guidelines, plus the appendices, which show you all about anticoagulant drugs and have a simple laminate on anaesthesia, are freely available. Periprosthetic fractures are a looming problem. Please get in touch with me. Thank you very much, and hope you all keep safe in the next year. Thank you.
Thank you, Dr. Richard Griffiths, for a so interesting lecture from your experience. So we will move to the question and answer. And I think we have to use the question and answer part for answering the question, because so many participants and they can do the raise hand. I think Dr. Prof. Bettelli already typing and answer one or two questions, yes? Yes. So maybe we will start from Professor Veering. Should I just read the question, or maybe you can just answering directly after you read the question. You have about 4 questions.
Are you speaking with me? Sorry.
Now with Professor Veering.
Yes, I don't
okay.
see. I don't see the question. I don't see the question.
So I just read it for you. The question, there is 4 questions for you, for Professor Veering. And
Oh yeah, I've got them. Yeah.
you can see that in the question and answer part.
No,
The treasure? No. So I will just read.
Yeah.
I don't know how to do it.
Okay, it's okay. I just read for you. The first question, there's no name on the question. Dr. Veering, what is your recommendation for geriatric undergoing minimal invasive procedure but high risk, especially the frail ones? What is your recommendation?
For what?
Yeah, for Dr. Frail.
For the frail patient.
Yeah, especially for frail ones. Minimally invasive procedure, but high risk.
Well, as Dr. Griffiths says, you should not have a drop in blood pressure. So the frail patient is eager to have a drop in blood pressure. So you need to have vasopressors and just do monitoring, just titrate with a little bit propofol, with a little bit remifentanil, and just with a lot of vasoactives and just very few for general anesthesia. Okay, so do fast track surgery, fast track anesthesia. Just that remifentanil, because they have to get up early, quick, and propofol as well. So very slow and very little. That's okay?
I think it's okay because there's no comment from the friend that.
Just the main thing is, as Dr. Griffith says, try not to have a drop in blood pressure.
Yeah.
So do a lot of vasoactive and very little drugs with a quick, so that the patient is wake up very quick. Okay.
Yeah. Okay.
Fast. Yeah.
At least I understand that. Thank you. And we move to the next question. Again, for Professor Veering. Thank you for great presentation. I have some question. Is there any correlation between intraoperative opioid and dementia postoperative in geriatric with major surgery? That's 2. Another question is there any recommendation what is better and effective analgesic for geriatric postoperatively that doesn't affect dementia post-operative? Thank you so much.
Well, as Dr. Bettelli also said, it's quite important to see it preoperatively if the patient has already factors for dementia. It's quite difficult. Sorry. It's very difficult to find the best solution for patients with dementia because actually we don't know exactly, as I show you with the EEG guided study, which is the best anesthesia for the patients. What the bottom line is, don't use too much. Again, fast track surgery and less opiates, because I think you will get a hangover of the opiates. And do a very good preoperative assessment, as Dr. Bettelli said. Don't you think so? Gabriella?
Yeah.
You are still mute. Okay.
Yes, Bernadette, I agree. I fully agree with you. I think that during the preoperative consultation, we have a great amount of possibilities to largely improve the surgical outcome.
Yes.
So
However, this this aspect is not shared, not well known inside the anesthesiological community. Many of the colleagues say, but I don't have time to do all that in the 20-25 minutes I'm allowed to use for each patient I have to evaluate. This is true. However, first, we need to geriatricize, if the terms can be used, you all. In other terms, the majority of us during his or her educational pathway never studied geriatrics. I had a master in geriatrics, but just when I arrived to be the director of a geriatric anesthesia department. Otherwise, I had no specific knowledge on this. That's why now I activated, and this, I'm very proud of this, I activated in Italy a second level university master, which is made in co-partnership by the University of San Marino, where I belong from, and the Catholic University in Rome. This master is a second level university master. It's open to surgeons, anesthesiologists, geriatricians, and nurses, and the name is Perioperative Care of the Geriatric Surgical Patient.
Okay, thank you. So your recommendation, Professor Veering, that it is depend on the preoperatively.
Yeah, because it's still not known which is the best anesthesia for the elderly. I think, as Dr. Griffiths says, the best thing is not to have a drop in blood pressure, either with regional anesthesia or with general anesthesia. And as I said, monitor the patient very well, and don't give too much anesthesia, because I'm sure, as the last speakers also said, don't give too much. We overdose the elderly. That's the problem, especially the frail one.
Okay.
I think, sorry guys, it's Richard. I think that's why it's very important that a cohort of anaesthetists develop. We spend an inordinate length of time in the United Kingdom training on pediatric patients. Just to give you an example, there are 10 times as many people over 65 with major trauma in England than there are children aged 0 to 16. So I think we've got to take a paradigm shift here. And what you find is, if you have a cohort of people in a hospital who do the same thing all the time, they get quite good at it. And that means, as Bernadette said, reducing doses of drugs. I think the biggest single mistake I see when I was in my clinical practice was propofol. People give much too much propofol at induction to older people. And what it does is it catastrophically drops the blood pressure. And there is stacks of evidence from Daniel Sessler's group in the United States, and a little bit that we did, showing that if you drop the blood pressure, even for very short periods of time, you're going to get things, end organ damage. So you're going to get acute delirium, acute kidney injury, acute myocardial problems. All those end organs will be damaged. So I think you've just got to be, I would think the good term that Stuart White in Brighton has termed is physiologically sympathetic. Keep the physiology as normal as you can.
Yes. Thank you, Dr. Richard. And as you know, in Indonesia, Dr. Susila also just organized the anesthesists that have special interest for the geriatric patient. But we just start now. So that's why this session is so relevant. We have about 600 participants now.
Yeah,
600. This
if I was an anaesthetist starting my career now, I'd focus on older people.
Yes.
Yes. Itu the demography trend. Yes. Now.
Yeah.
Thank you. We just stopped for this topic, and still for Professor Bernadette, what is your opinion on dexmedetomidine to prevent post-op delirium?
I must honestly say I don't have any experience with this drug. We don't use it in my hospital. Maybe the other ones, maybe Richard or Gabriella, but I don't have any experience. But it's just new in the literature. People are ongoing using it because when you know exactly how to use it with less dose, then the chance to have a delirium is decreased. That's what I read. But I don't have any experience. Sorry for that.
Yeah.
But it's a drug which is ongoing popular now.
Yeah, it wasn't licensed in Europe. It was licensed in the United States a lot many years ago, and then mainly used for intensive care unit sedation, and that's where it's used now in England, in the United Kingdom. But we've got very little experience of it. I think the golden rule is, though, for any pharmacology you introduce to older people, you're going to have side effects. And those side effects are going to be heightened. So I think just be very careful. The one good thing that you can do, and Bernadette is more of an expert than this than me, is regional blocks and nerve blocks are very good. Because if you can reduce opioids and even reduce non-steroidals. So we've got a question on selective COX-2s. We don't use those in old people. I mean, I think the bad press they got with heart problems, it's just not worth it. But nerve blocks, and the other very good thing that surgeons can do is just local infiltration with local anaesthetic. So in an elective hip operation, just get the surgeon to put in 100 mils of 0.125% bupivacaine. Very, very effective, very cheap, and doesn't affect the central nervous system of the old patient.
Okay.
Simple techniques.
So thank you. And you have a comment, Professor Gabriella Bettelli. You have any comment about these drugs? In Italy, maybe?
Oh, as Bernadette and as Richard, I have no direct experience about dexmedetomidine. I know, because I was part of the task force who wrote it, that the ESA guidelines on the postoperative delirium recommend using this drug in patients where the non-pharmacological treatment of delirium reached any result. I know that he is being introduced in Italy, but I don't have direct practical experience on the field.
Yeah. Thank you. So we move to the next question about, they ask also about the Celebrex for geriatric patients.
Don't use it.
Experience, not just that. This is for Dr. Bernadette, Professor Bernadette. Any comment?
The question
is about, wait a minute,
the use of celecoxib in geriatric patients.
Yeah.
Oh,
Yeah, selective COX-2 antagonist is what you're talking about.
As Richard said already, take care with this drug because of too many side effects. Okay?
Yeah. Yes.
So we don't use it, no.
Yeah.
Richard, do you use it?
No, not at all. Not at all. We don't use non-steroidals full stop in old people. I think you've got to be very, very careful. And I think the COX-2s scientifically were an extremely interesting group of drugs, and everyone thought, oh, we can get rid of the problems. But in practice, when they were introduced, there were major problems. So they're really not used. I mean, paracetamol is pretty effective, actually. Use paracetamol. Combined with nerve blocks, that seems to be extremely effective.
Yeah. There are too many side effects.
Yeah.
There are too many side effects. That's the problem. I agree. Probably Gabriella and Richard as well, that you should take paracetamol. And the dose is the same in the elderly compared to the younger ones is paracetamol.
Yeah.
Thank you for that. So paracetamol is enough, yes? I think so also that it is as simple as that, paracetamol. And then we move to the question for Dr. Rishan.
Yeah.
In your slide, you wrote that we have keep patient with hip fracture in normotensive. How about the patient with hypertension? Is that mean that we have to keep literally normotensive or normotensive due to her blood pressure baseline?
Yeah, you go on the baseline. So it's extremely important that you look at all the documentation, and you have to keep the patient normotensive. There are some extremely good techniques for spinal anesthesia. You can get away with 5 milligrams of levobupivacaine for a dynamic hip screw. You only need a block to L1 T12, and if you look at our guidelines, we quote a couple of very, very good papers. There's one particular one from Israel, which was the Ben David paper. They actually added opioids into the mixture. We don't do that. I think opioids in old people in spinals is bad news as well. But this is a whole team approach. What you need a surgeon who can do the operation in an hour. You don't need a trainee surgeon who's going to muck about for 2 or 3 hours, because your block will wear off. So you need an experienced surgeon, you need an experienced anaesthetist, and you can get away with very low doses. The other really, really important thing in these hip fracture patients is to look to see when did the hip fracture occur. And you count from then onwards, so that's the time of injury. You need to know how much resuscitation has gone on. They have to have had IV fluid. They must be resuscitated before you take them to theatre. That is really, really important. And the big problem is people who put drips in here. Do not put a drip in the cubital fossa in an old person, because when they go to bed at night, they just do that and nothing works. So have a very, very close look at fluid balance. Very, very important. But normotensin, absolutely crucial, absolutely crucial. And as I mentioned a little bit earlier, look at all the studies. There's again a great Dutch study looking at cerebrovascular problems and hypotension in old people. You will get end organ problems. And a lot of the things like acute delirium which occur are related to hypotension. So if you drop the blood pressure in an old person, you will affect their cerebration post-operatively.
Okay, thank you for that. And we move to the last question for the session. I think it is for Dr. Griffith again.
Yeah.
What is the recommendation to maintain post-operative pain until the day 5th? Using epidural catheter or intravenously?
No, epidural catheters have gone out years ago. We don't touch them with a barge pole. The most important thing you have to think about in these patients is they've got to get up. They get up that afternoon if the operation's in the morning.
Yeah.
You have to mobilize them as quickly as possible. And the way you do that is you can do local infiltration in analgesia, you can do fascio-iliaca blocks and use simple analgesics like paracetamols. Avoid non-steroidals and avoid opioids. So I'm talking here about hip fracture, which is different to hip arthroplasty, a total hip replacement. Now, you can do total hip replacements in as day cases. They are being done. But in hip fracture, the one thing which stopped old people being mobilized when a study was done in our country was low blood pressure and pain. And basically, if you do nerve blocks and paracetamol and you keep them normotensive, you conquer that problem. Okay, epidural catheters, well, I haven't seen one used, 15 years. Just don't do it.
As There's also the problem with anticoagulantia, of course. Always the discussion with the surgeon, so therefore you should avoid it.
Yeah.
Okay. No comment, Professor Gabriella?
No, I agree with my colleagues fully.
Okay. So I think there's still a question, one or two. The last one is for Dr. Griffith.
Yeah.
In your recently published guidelines of hip fracture, the proportion of general anesthesia plus peripheral nerve block is bigger than regional anesthesia. Any analysis why many anesthesiologists in your country prefer choosing this technique?
What, general anesthesia?
No, plus peripheral nerve block.
Yeah, well, so the question is general anesthesia plus nerve blocks.
Why do you prefer to choose that instead of neuraxial block? I think.
Well, the thing is, I mean, I'm a very pro spinal anesthesia person. Neuraxial block.
Yes.
We cannot prove. We have been unable to prove that it's better.
Yeah.
Okay. So the important thing to do is make sure everybody gets a nerve block. Okay. Because that will give you opioid sparing anesthesia. But there is very, very little evidence that doing a spinal anesthetic is better than a general anesthetic. I mean, these two big studies that are going on, one in the United States, one in Germany and the Netherlands and Belgium, may give us an answer. I doubt they will give us an answer because they're only studying 2,000 patients. You're probably going to have to study 30 or 40,000 to get a difference. Because I think we're deluding ourselves if we think that our 1 hour intervention is going to make a difference on a post-operative course of many days for these patients. That is the really important thing. And the other thing you have to consider is that when you do regional anesthesia, I never give sedation, but a lot of people are giving all sorts of stuff, which actually makes it a GA anyway. But the reason is that we've gone in our guidelines to say, whatever you do it sympathetically. So I think it's more important probably to maintain normotension than actually to choose if you do a GA or a regional. And so what we've gone away from is from anaesthetists thinking that a spinal is the solution to suddenly taking a step back and thinking, what we've got to do is to keep these patients physiologically normal. So, and I will maybe next year, those studies will be published. I will bet anyone they don't find a difference.
Okay. So I think it is a good answer because it is in England, yes? Maybe it is different with Indonesia, Dr. Susilo.
Who knows?
Yeah.
Who knows?
Who knows? I mean, I do all spinals. I do almost all spinals, but I'm biased, but I do appreciate that we haven't found a difference.
You're right.
Yeah.
It's different things, yeah.
Yeah.
So I think it is the time that we have to stop this excellent and nice discussion.
I've got to go cycling.
Oh, yeah. You have a time now.
Yeah, I'm going cycling with my wife, yeah.
I will go to have my run, my 10 kilometers run.
Yeah.
Okay, so thank you very much for Dr. Bernadette Veering, Professor Bernadette Veering, Professor Gabriella Bettelli, and Dr. Griffiths.
Thank you.
Thank you.
Bye, guys.
Thank you to you all.
Thank you.
Thank you.
See you
Thank
next
you.
year.
And next year.
Thank you.
Yes.
Thank you.
Thank you,
Thank you
dear.
again, Susili. Thank you again.
Thank
So
you.
back to Chris.
Bye-bye.
Thank you. Bye.
Bye.
Bye-bye. See you.
Bye, Gabriella. Bye, Rachel.
Bye.
Thank
Bye,
you.
dear.
All right, so it was a very, very interesting
Terima
session.
kasih Prof. Rita.
Iya.
Sama-sama Pak Edi.
Prof. Rita for delivering such a wonderful discussion. As already mentioned before, I think it's a good time to start to think about geriatric anesthesia because as we've seen in the previous presentations, the number of geriatric patients are increasing, including those who will undergo surgery, right? I think the same in Indonesia, right?
Yes.
Yeah, Dr. Eddie and Prof. Rita already mentions. So for those who are interested in geriatric anesthesia, I think this is the time. All right, so that concludes our afternoon session. But for today, we have one more session.
One more.
Everyone, so thank you and until we meet again. Dr.
Okay.
Eddie, Dr. Gabriella, and also Rita. Bye, terima kasih banyak.
Thank you, Prof.
Okay, so for the next session, last session of the day, we will have 30 minutes break. But after this, we have a very, very unique session called Hidden Treasures. So, apa nih yang hidden?
Bahasa Indonesia harta karun. Berarti bakal seru.
Berarti bakalan seru. Jadi untuk teman-teman yang masih stay, berarti pengumumannya jadi nggak sekarang ya dok ya? Pengumumannya nanti jam 8.
Iya, oke. Setuju. Pengumuman giveaway.
Untuk teman-teman boleh istirahat sebentar, 30 minutes.
Isoman.
Yeah. Kita akan kembali lagi jam 6.30 untuk sesi terakhir hari ini. Judulnya Harta Karun. Menarik banget kan? Ini kalau nggak salah request special kan sih?
Iya sebetulnya. Semangat.
Judul jarang-jarang Indonesia itu biasanya milih judul tuh Dr. Edi loh. Ini
satu-satunya ya. Sepanjang 18 kali baru ini. Kegatelan
Chairman langsung ya.
Nggak pernah loh. Seumur 18 kali berapa ribu sesi ya dok ya?
Iya.
Nggak pernah dokter Susilo ngasih judul. Nah ini judul sesi nih. Jadi buat teman-teman, terutama rekan-rekan yang Indonesia, kita akan kembali bergabung jam 6.30.